I'd like to tell you about a case that I'm very fond of, one of my favorites. It was both intellectually and technically challenging. I have no disclosures or conflicts. The case was that of a 41-year-old woman who underwent neck fusion surgery for degenerative joint disease. She unfortunately developed a left leg DVT 3 days later. As anticoagulation was deemed to be relatively contraindicated so soon post-op, instead she received a temporary IVC filter. Unfortunately, she still developed a pulmonary embolism within another 3 days. It was low risk. Anticoagulation was commenced not until 2 weeks later. Subsequent to that, though, she did develop bilateral iliac vein thrombosis. 2 attempts were made unsuccessfully to retrieve the IVC filter 6 months later. Around 8 months later, she was referred to me for both removal of her IVC filter and evaluation of exertional dyspnea. In addition, she had left leg aching, mild edema, and she wore compression stockings. She recalled that prior to the surgery, DVT and PE, she could go to the gym and use treadmill. Since the event, merely walking up the stairs made her feel as if she was going to die. She became quite tachycardic within 30 seconds of walking. I examined her and her heart and lung sounds were normal. She had mild edema, left worse than right, with no pigmentation or ulceration. We also repeated her CT venogram that showed common iliac vein occlusions bilaterally extending into the IVC confluence. So the question remained, why was she dyspneic on exertion? Was she deconditioned? Did she have chronic thromboembolic pulmonary hypertension? Or was it something else? We performed a battery of tests, including a VQ scan that showed no defects or mismatch. Transthoracic echocardiography suggested normal biventricular function, no valvulopathy, and normal RV pressures. Right heart catheterization confirmed normal right and left-sided filling pressures and normal pulmonary artery pressure. We also performed an exercise treadmill test. It revealed no ischemia, although she became quite tachycardic with exertion. Pulmonary function testing was also normal. A 6-minute walk test resulted in severe dyspnea, and she only completed 61% of the expected distance. We considered the possibility of deconditioning and suggested that she exercise, but a 2-month exercise plan did not help. So the question remained again, why was she dyspneic and tachycardic on exertion? Could she have preload insufficiency? After all, she had bilaterally occluded iliac veins, and perhaps the venous return was inadequate. So I decided to intervene, starting with the IVC filter, which was retrieved using a standard retrieval device shown on the right. We then performed venography through the common femoral veins, and this revealed bilateral occlusions as suspected, but wiring these occlusions was not all that straightforward. So we used a very helpful trick, which is to leave small gauge venous sheaths in place and to infuse low concentration but high volume TPA overnight through both sheaths through the occlusions. Typically, this results in the development of visible microchannels on venography the following day, which will make an intervention much easier. The image on the left shows the intervention. A typical approach that I've used is to use a 6-French guide through which a glide catheter can be placed, and through that a stiff straight glide wire. And using the so-called Triforce technique, one can get through venous occlusions with general ease. Intravascular ultrasound shown in the image on the center showed post-thrombotic changes. After venoplasty, a 14/90 self-expanding stent was placed, which led to restoration of flow in the right common iliac vein, but we could not restore flow on the left. The patient was discharged on 2 weeks of enoxaparin. Subsequently, this was switched to a DOAC. Almost immediately, she noticed a marked improvement in her exercise capacity. She resumed regular exercise and went back to the gym. She repeated the 6-minute walk test, and there was an improvement. She completed 360 meters before. This improved to 449 meters. Previously, she was at 61% of expected, and now it had risen to 76% of expected. Of note, edema improved not just in the right, but in the left leg also. This was a very interesting observation, but it's worthwhile looking at some of the things in the literature that could pertain to what we found. In a database of patients referred for clinically indicated invasive cardiopulmonary exercise stress testing at MGH, a group of 49 patients with unexplained exercise intolerance were identified. And these patients were found to have a low VO2 max due to inadequate peak cardiac output, but normal BiV ejection fractions and without pulmonary hypertension. These patients had lower right and left-sided filling pressures at peak exercise despite an IV fluid challenge. They had a decreased stroke volume augmentation with exercise compared to controls. And the authors postulated that the low venous pressure leading to low ventricular filling can cause exercise intolerance. This might be due to inadequate venoconstriction of capacitance vessels. In the case of our patient in this case, she had bilaterally occluded iliac veins, so her venous return was not adequate to meet the demands required to fill the RV, and therefore she developed exercise intolerance. The tachycardia may have been a compensatory. The lessons learned from this case: first, diligent methodic workup applies to this case as well as any other. Second, procedural planning is vital. And lastly, adequate venous return matters. Thank you very much for your attention.